Thank you, Blair, and everyone. I'm just thrilled to be here, and it is not because I'm leaving snowy Washington, D.C. It's that I'm able to come and talk about a subject that all of us care so deeply about and spend time with such respected colleagues and professional associates and really discuss this at what I believe is a pivotal moment for the lung cancer community. It's wonderful. I have medical professional advisors on our board that are here, Blair, Doug Wood, Raja, and another interesting fact in my research, looking at your organization before coming, learning that Dr. Ginsburg, who obviously was a foundational member to all of you, was also a foundational member to us as an organization. In fact, he was one of AllCase, which is the predecessor name for Lung Cancer Alliance, board members. So it's very synergistic that we would find ourselves here and with the opportunity for me to talk with you, knowing that we've had a long and deep relationship over the years. Now, I'm thrilled to be able to talk after the two speakers because what you've heard is the on-the-ground experience of setting up a screening program and what that means and what I hope I can do from a patient, and I should say consumer perspective, because the majority of people, vast majority of people that we're talking about are people who are at risk, have not been diagnosed. So I'd like to be able to give a perspective from the consumer, but take this up to the national level, the macro level, and really talk about what's happening across the country in terms of responsible implementation, and also what is happening on the coverage and reimbursement side, which obviously is so critical to this. At the end of the day, we do not want barriers to access for what is a proven life-saving benefit. And how we go about this right now, showing that screening can be implemented responsibly in a fairly standardized and uniform way, along with ensuring that the policymakers understand this so that we can move coverage and reimbursement forward as quickly as possible. Now, I have no disclosures to report, and for those who don't know the organization, it's one that is the only one in the country that is devoted exclusively to those living with or at risk for lung cancer. And we have a robust support initiatives, but what we also do is be the voice in Washington, D.C. and ensure that public health resources and infrastructure are best directed to the entire community. So, let me just move through this quickly and get really to the meat of it. Here we go. So, we're going to step back. NLST is halted early, and I want to just talk a little bit about that 20% endpoint because it has been used by some as though it is a ceiling and not the floor. It was a trial that was halted early because the endpoint was reached quicker than anticipated, and if rounds of screening were actually extended, we could see the mortality benefits certainly much greater, and obviously the studies subsequently have shown that. We're talking about tens of thousands of lives that would be saved, and what we as an organization needed to do was answer the questions that were being put to us from consumers. Am I at risk? Should I be screened? Where do I go? So we set about creating guiding principles and a framework to help navigate these critical questions. And I will share with you that we receive and speak to thousands of people a month. And while the majority of information that comes to us are from those who are obviously diagnosed and want to know what this means, we began receiving calls about, am I at risk? Where should I go? Because, of course, from our perspective, it is also incumbent to only direct where responsible care is being provided. So we established a framework that had three parts. It spoke to consumers. Consumers have a right to know that they could be at risk, and they have a right to know where responsible screening is being provided, but more importantly, what constitutes responsible screening. And they have a right to know that there is a commitment to a quality improvement process that's embedded in all of this. And we got together with a multidisciplinary team of doctors. We created this document. It was actually announced and launched at the NCCN meeting over 2 years ago. Many of you in this audience are working at what we refer to as our Centers of Excellence framework sites, because it has been a way for us to work collaboratively with the multidisciplinary teams and set this up now. Not waiting, but now, because again, the demand that we were hearing from the consumers. So the framework was intended to educate, give guidance, and assure a commitment to a quality improvement process. So what we have today, believe it or not, it's actually upwards of 200 centers that we are identifying across the country. This is amazing to think that what we could do is push this out. Now, it doesn't seem like many at the moment, but to know that we are now receiving 2 to 3 calls a week from hospitals saying, can you help us do this? Can you give us guidance? More importantly, what we're being able to do is connect hospitals to one another so that the lessons learned from other facilities can be shared. We have over 200 hospitals that are what we deem centers of excellence, because again, what we're hoping to be able to be is a third-party validator of responsible care. This is growing. What we are being able to share is that I think it's about 2/3 of these are actually at the community-based level. Rural, urban, academic, medical, community-based. What we have been able to show following these guiding principles that include making sure that you're communicating appropriately to those consumers and patients, that you have a multidisciplinary team in place, that you're following best published practices, i.e. NCCN, ILCAP, that you are embedding smoking cessation, that your surgeons are board certified, and that you're also allowing consumers to know that they can be a part of research by sharing their images or any other biomedical samples, and that as an institution, you also support the need for a quality improvement process. These are the guiding principles of the framework, and the sites that are following these are what we're identifying and pointing to. It's scalable, it's replicable, and it is being embedded in a variety of settings. This is what we are using to share with policymakers, that moving forward now is actually okay to do, and that screening can be done well and right. Now, we've heard many discussions around this, so I don't want to repeat, but obviously that B recommendation was critical. And I will tell you, we have been pushing and pounding, because making sure that Preventive Service Task Force made this recommendation at the end of 2013 is allowing for us not to have to wait till 2016 to see coverage and reimbursement come into place by the way in which the Affordable Care Act was written. We would have had a delay of an additional year. And when I say nail biter, I mean nail biter, because this announcement came forth literally at 5 o'clock on December 31st, which meant that we could move forward and hopefully see, governed by law, the coverage and reimbursement literally this time next year. Now let me walk through that a little bit so that you understand. The Affordable Care Act now mandates that any preventive service that receives an A or B is automatically considered an essential health benefit. So right now, lung cancer screening is considered an essential health benefit, and by law, any new private insurance plan and the state health exchanges have to include lung cancer screening, literally this time next year, by January 1, 2015, in any new plan without co-payments. It'll be done. Now, the grandfathered plans, those are the primarily the bigger, larger employer plans, are not required. But you are seeing many of these big plans moving to incorporate and following the US PSTFB. Many of them will say to us, it's a done deal, it gotta be. We'll be moving forward and doing this and making these changes. I'll come to the Medicare issue next, but this also will give you an idea of where the private insurance coverage is. And I know we talked about it a little bit this morning. Blue Cross Blue Shield screening is the lighter blue. Aetna screening coverage is in all 50 states. We are working with the private insurers, and I appreciated the reference to the cost-benefit analysis, because I'm very proud to say that Lung Cancer Alliance, along with Legacy Foundation and the Johns Hopkins School of Public Health, worked very hard with Milliman to produce what we called our trifecta. It was a three-part analysis, actuarial-based for commercial population, but the first one was on the mortality impact, of which obviously tens of thousands of lives would be saved, but the cost benefit and the cost utility analysis referenced earlier are critically important to our outreach right now to the private payers, showing that screening effectiveness and its utility are on par with cervical and colonoscopy and superior to breast cancer, as well as HIV. This is the information that we are having put forth in front of the private insurers at this moment to move them forward rapidly with coverage. So you've got your uninsured, your Medicare population, Medicaid, the VA and DOD as a sidebar. Again, we have worked directly with both, and I'm very proud to say, and particularly DOD and Walter Reed and its flagship facility, they're on fire. They are launching their screening program. They are a center of excellence within our framework. We now have the VA moving forward with 8 sites, so this is actually happening among government entities that we have been in direct a partnership with, and thrilled to see what's happening. And San Diego will be next. Portsmouth is also screening for the DoD facilities. So they're moving, which is great. The employer-based plans, again, 30% of these are grandfathered, but by this time next year, you'll probably have upwards of maybe 20% that still will not have embedded lung cancer screening, but they're moving forward rapidly. Now, okay, let's get into where we are with CMS, because it's been an amazing set of circumstances. But the National Coverage Determination has been launched, as you all know. Lung Cancer Alliance requested it formally in October. Dr. Peter Bach also requested a national coverage determination. So we had competing requests in. And I'm pleased to say that CMS reached out to us and had allowed us to have conversations, but more importantly, I shouldn't say more importantly, because it was a little bit surprising that they moved forward in announcing that they were going to launch officially their national coverage determination and set up what is referred to as their medical coverage analysis committee, a MedCAC meeting, where they can hear from public speakers about the benefits of moving this forward for that population. We were hoping to be able to shape how CMS would go about this before they made that formal announcement. But what this stimulated was a coming together of a very strong and deep consensus among the primary leaders in this who have the direct responsibility for moving screening forward, and that's the American College of Radiology, the Society for Thoracic Surgeons, and Lung Cancer Alliance. So we forged a wonderful working partnership to think through how do we communicate to CMS at this moment and ensure that they are provided the information to make this determination. I'm a patient advocate. The fact that we even have a MedCAC to me is astounding. because we have sufficient scientific evidence. We have had the review of USPSTF. This shouldn't be delayed. I don't think we should be going through as many hurdles as we are. But this is the first preventive service to be put forth after passage of the Affordable Care Act, and I think they're trying to figure out if they're doing this with the proper way, because this will be looked to as precedent setting for how other preventive services under the new law are acted upon. Now, just going through this process, yes, it was referenced earlier, but it has been an interesting wrap-up to these, build-up to this meeting because of a public comment period that ended on March 12th. We have been working around the clock with many societies. In fact, of course, with Doug Wood here, who led this for STS, we have a almost 30-page document that was put together. I have here, I actually made a couple of extra copies, but I certainly will make sure if anyone would like emails to it. But this is the document that was developed that in essence strongly advocated for the USPSTF-B recommendation, provided the expert advice as to how to set up screening programs and look at the downstream management and the structured reporting, recommending that we have coverage with evidence for the other at-risk groups, i.e. the NCCN categories, as well as supporting and leveraging the existing databases and registries that we have today to further refine our understanding of this process. So I think that this is seminal, and I know we're going to build on this and now begin to pivot toward how we can, for this public meeting at the end of April, ensure that the right information about implementation and the benefits that this will be providing to the Medicare population, of which all of us in this room know 60% of lung cancer diagnoses fall on the Medicare population. If we put barriers to access or restrict this life-saving benefit, that is just, it would be a non-starter. So we are moving through the public comment period, but again, what we have is a proposed decision memo that will be forthcoming from CMS, expected November 11th. There's a final public comment period, and then by February 2015, we should have their final determination. That is the process for CMS right now. There is one other hurdle that is a technology assessment that they could say they need to undertake, evaluating, obviously, the technology surrounding this. Again, I don't feel that that is necessary, but there are some that are suggesting that we don't have enough information, the research isn't sufficient, we need to be collecting more data, and we really should be focusing our resources more on biomedical research than actually implementing this at this time. So, we step back and we look at the national landscape, and everyone here would know this better than most, is that we really have a new preventive service that is a targeted benefit. We have technology advancements since the NLST that have further refined the risk and improved our opportunity to find and detect this disease at smaller and curable stages. We have surgical improvements that I don't need to go into detail here that certainly have reduced morbidity and have reduced hospital stays. We have a mortality benefit, cost utility. The most important thing that's underway now, though, is how we are already moving forward in terms of looking at the collection of data and analyzing that to further refine this process. So this is a no-brainer from our perspective, and it should not be that difficult to get this moved forward. We've already seen it in this room. Almost 3/4 of this room have screening programs in place. So if you really think about lung cancer screening and what it has done to the continuum of care, we now have our three-legged stool. What we know with screening is that you have more personalized and teachable moments in which to have those who are current smokers understand that they really should quit and help them through that process. We have a new cessation tool through screening. And we have shown, research to date has shown that we have higher quit rates among current smokers when they are screened for those reasons. But what we also have now is the opportunity to probably accelerate research, in my view, in ways that we haven't yet seen to date. Because for the first time, we're going to have access to biomedical samples at earlier stages of the disease, and more of them, that will help us drive genetic and molecular testing, but also better treatment research. We now have a continuum of care for the disease in a way that I think is profound, that we really haven't seen for other screenings going forward. So I will tell you that it has been a battle that I don't think should have been this hard. Shouldn't have been this hard. But I would like to believe that what we now have is the U.S. Navy formed. And we are not going to let pirates own the high seas any longer. I think the CMS process has allowed for us to really think about how do we come together as stakeholders and ensure that we, those most directly responsible for this, are providing the expert advice and serving as references to help assist. Show that screening can be done in a variety of these settings. Advocate that we do not put barriers to access and that we actually use this opportunity to pull through a preventive service in a very cost-effective and efficient way. So I will end with a big thank you, because it is the surgeons who really are driving how we can do this well and right. And you have shown a consistent commitment to advocate for what is in the best interest of these patients, and that's respected. And you should be very proud through AATS, STS, and my gosh, Doug Wood, who has just done extraordinary work these past few weeks on this public policy and political issue. All should feel very, very proud, and on behalf of our stakeholders, I say thank you, and we look forward to working together collaboratively to pull this through to the very end. We're going to win this battle, I have no doubt. So I look forward to questions later, and thank you very much.